I'm Dr. Victoria, and this is George.
Today, we are going to be talking about deprescribing proton pump inhibitors. George was initially prescribed a proton pump inhibitor to help his acid reflux. He missed his follow-up appointment and just continued to take this medication without thinking anything of it. How long has your patient been on a proton pump inhibitor and why? These are important questions to ask yourself as we move forward. Available proton pump inhibitors include Omeprazole, Esomeprazole, Dexlansoprazole, Pantoprazole, and Rabeprazole. Reasons why a proton pump inhibitor might have been started include acid reflux, but also dyspepsia, reflux esophagitis, peptic ulcer disease, hypersecretory conditions such as Zollinger-Ellison syndrome, or as part of a multifactorial treatment for Helicobacter pylori. As well, patients are started on these medications in the hospital in the setting of acute GI bleeds and prophylactically for GERD during hospitalization. Sometimes patients who have been started on these medications in the hospital continue to take them even though they are no longer needed. Let's go over the correct dosing for proton pump inhibitors to ensure that our patients have had an adequate trial before we start deprescribing this category of medication. Proton pump inhibitors should be administered 30 to 60 minutes before breakfast, should not be administered at the same time as a histamine 2 receptor antagonist, prostaglandin E, such as misoprostol, or somatostatin analogs, such as octreotide. These anti-secretory agents may be used at a different time interval, such as nighttime or a period after breakfast, but not together. There are specific doses for our PPIs. Let's start with Omeprazole. For mild intermittent disease, this will be less than 2 episodes a week. Patients may take 10 milligrams once daily and can increase to 20 milligrams daily after 4 to 8 weeks if necessary. Patients should discontinue once asymptomatic for 8 weeks. For severe symptoms, that is more than 2 episodes a week, patients should start with 20 to 40 milligrams once daily, and treatment should continue for 8 weeks once asymptomatic. For Esomeprazole, we start with 20 milligrams once daily for 4 weeks, and if symptoms do not resolve, an additional 4 weeks is appropriate. For Lansoprazole, for mild intermittent symptoms, we start with 15 milligrams once daily for 8 weeks, and then once symptoms are controlled, to continue treatment for at least 8 weeks. For severe or frequent symptoms, 40 milligrams once daily, and continue treatment for 8 weeks. For Dexlansoprazole, we prescribe 60 milligrams once daily for 8 weeks. For Pantoprazole, with mild intermittent symptoms, we start with 20 milligrams once daily and may increase to 40 milligrams once daily after 4 to 8 weeks if necessary. Medication should be continued once asymptomatic for 8 weeks. Severe or frequent symptoms should have 40 milligrams once daily, and then once symptoms are controlled, continued for 8 weeks once again. For Rabeprazole, for mild and intermittent disease, patient can start with 10 to 20 milligrams once daily. If starting with 10 milligrams, they could be increased to 20 after 4 to 8 weeks if necessary, and treatment should continue for 8 weeks once asymptomatic. For severe or frequent symptoms, patient should be on 20 milligrams once daily and continued for 8 weeks once asymptomatic. Why would we want our patients to stop taking proton pump inhibitors? This is because of the side effects caused by this group of medications, and good medication stewardship, of course. When it comes to proton pump inhibitors, it gets more challenging as they are available over the counter, and good education on side effects should be shared with our patients. Long-term use of proton pump inhibitors can lead to Clostridium difficile infection, pneumonia, hypomagnesemia, and increased fracture risk, as well as increased risk of enteric colonization with multi-drug resistant organisms. That being said, some patients should continue to take proton pump inhibitors. These include patients being treated for Barrett's esophagus, chronic NSAID use with bleeding risk, severe esophagitis, chronic hypersecretory conditions such as Zollinger-Ellison syndrome, a documented history of bleeding GI ulcers, and patients currently undergoing treatment for H. pylori. Several methods exist to start transitioning patients off these medications. We recommend that over the next 8 weeks, engaging in joint decision-making with your patients to have cessation of proton pump inhibitor use. Stepping down includes abrupt discontinuation or tapering of proton pump inhibitors, followed by initiation of histamine 2 receptor antagonists, including famotidine, the most ideal medication in this drug class, cimetidine and ranitidine, and nizanidine. So, you can either abruptly stop the medication. If using this method, discuss with the patient the strong likelihood of rebound hyperacidity. Or engage in a tapering of the medication, either by decreasing the dose by 50% over the next 4 to 6 weeks, or increasing the interval between doses to every 2 or more days. When starting to transition patients off proton pump inhibitors, we recommend a tapering of 2 to 4 weeks, as this likely mitigates rebound hyperacidity. In addition, the use of histamine 2 receptor antagonists, we also want to encourage the patient to engage in lifestyle modifications, including waiting 3 hours before lying down to rest after eating, not eating 3 hours before bedtime, avoiding tight-fitting tops, and avoiding caffeine, as this can relax the lower esophageal sphincter. Common culprits for acid reflux include coffee, soda pop, caffeinated tea, and chocolate, as well as some other triggers that can be personalized for the patients, including citrus foods, spicy foods, and fatty or fried foods. Lastly, using an extra pillow to raise their head when sleeping can be helpful. I'd like to encourage you to have more frequent follow-up with your patients in the next 1 to 2 months so you can see how their progress is going. I'd like to encourage you to be as intentional with your follow-up visits as you would be with smoking cessation or management of depression. Thank you for joining me today, my healthcare team. I wish you luck in deprescribing your patients' proton pump inhibitors. I hope you'll join us next time to see what George gets up to next. Bye-bye.